that is an interesting thing of adapting treatments from clear cell and then testing them in non-clear cell, which has been a pattern for a long time. Not all non-clear cell, collecting duct medullary, that has actually historically responded to chemotherapy, which most renal cell carcinomas do not. But by and large, it has been this mTOR, TKI, and now immunotherapy, and then the combinations of those that people are testing. Again, coming from the clear cell world, some of the studies actually allowed all renal cell carcinomas, and then a subset were non-clear cell, but the numbers were quite small, and so it was hard to make definitive conclusions from those trials when they contained only 5 patients with chromophobe, for example. What do you make of that? So I think the over time there's been greater and greater recognition that this doesn't make a lot of sense in some cases to treat these entities as being similar to clear cell or similar to one another necessarily. Now, there have been successes though, and so I think that's important to highlight. Of many of these renal cell carcinomas do seem to respond to some of these similar therapies. Again, I think there's a lot of work left to be done in terms of the molecular drivers, which are certainly unique between these different cancers. But the TKIs and immunotherapies that we now have seem to work across a broad range of tumors. And so I think that has been fortunate that many of the TKIs are also multi-tyrosine kinase inhibitors. So they hit multiple different pathways. And so we're seeing efficacy in these different tumor types. So it's kind of an interesting dynamic that we're lumping them together. We're testing them in the same agents by and large as in clear cell, and yet we are seeing some success with doing that. First on the list is clinical trial, which of course is, I think, always a good option, especially in non-clear cell histologies. Cabozantinib single agent, cabozantinib plus nivolumab, which we discussed, lenvatinib plus pembrolizumab. So that's under the preferred regimens. And then you start to get pretty into the weeds, although with other recommended regimens, although I think everolimus lenvatinib is a strong second regimen if you don't use lenvatinib pembrolizumab in the first line. I think particularly in chromophobe, so metastatic chromophobe. Chromophobe does seem to be mTOR pathway driven quite frequently. We do have a retrospective that was presented at ASCO, main ASCO this year, looking at how different patients did with different regimens, and the mTOR plus TKI group did quite well with all the caveats that come along with the retrospective analysis. So I think that sort of piques my interest in, especially in metastatic chromophobe, if you use potentially ipi-nivo, which I expect will be added to the preferred regimens based on the study forecast. If you use that in the first line, then using everolimus and lenvatinib in the second line. So, and that might be a good regimen, for more than just chromophobe. I think it could potentially be a good regimen for papillary as well.